and with my co-chairs, we will introduce the speakers for this session. Of course, our first speaker for this session needs no introduction. He gave a fantastic talk on regional therapies for HCC. So Professor Jin Wook Chung will come back again and talk to us on the role of conventional TACE in early and advanced HCC. Professor Chung.
Thank you for your kind introduction. Actually, conventional TACE is usually indicated in intermediate stage. Today I want to talk about the role of TACE in early and advanced HCC. This is a BCS staging system and treatment recommendation. TACE is recommended in the intermediate stage. But this is the real situation in Korea. Between 2003 and 2005, we started investigating the initial treatment for HCC. Surprisingly, at this period, almost 70% of patients were initially treated by TACE, except the best supportive care. Among the treated patients, TACE was the initial treatment in 70% of patients. 5 years later, it was a little bit decreased due to introduction of sorafenib and also more popular uses of local ablation. But still, more than half of the HCC patients are initially treated by TACE. How about in the world? You can find this article. So HCC bridge study, 42 sites in 14 countries participated in this study, and they investigated the initial treatment modality for HCC. If you look at the outcome, Taiwan, South Korea, Japan, only one site are involved, so it is not reliable. So if we look at the North America, Europe, and China, multiple sites participated in this study. Here you can see the TACE still the most commonly performed initial treatment throughout the continents. Of course, in BCSB, TACE is the predominating initial treatment, but even in stage 0 and A, TACE is widely performed, and the stage C is TACE is the predominant initial treatment, even in stage D patients. So here you can see a big discrepancy between guideline recommendation and real life practice. So there are questions. Is it overutilized, or are there underestimated reasons in the real world to use TACE beyond guidelines? So today I want to talk about role of TACE in early stage, advanced stage. So I want to finally introduce the currently revised Korean Practice Guideline, 2019. The curative potential of TACE has already been demonstrated by Professor Matsi in Japan 20 years ago. On histopathologic study, he demonstrated total tumor necrosis in a resected specimen for small HCC. And here you can see the long-term recurrence rate was only 33% at 4 years. And also nationwide cohort in Japan demonstrated very good long-term survival in early stage HCC after TACE, more than 50% 5-year survival rate. In the previous lecture, I showed you the ideal endpoint of conventional TACE in small HCC. This ideal endpoint only can be achieved in tumors smaller than 5 cm. If the tumor is bigger, this ideal endpoint cannot be achieved. So, conventional TACE is best suited for small tumors. And like this, the tumor feeding artery should be castrized, and if the portal vein appears, then embolize it. If you can achieve this ideal endpoint, I can guarantee that more than 2/3 of cases will be completely necrotized. Complete necrosis do not mean complete response on initial follow-up imaging. I mean that no recurrence during a 5-year follow-up period. So, if TACE is precisely performed, we can expect complete local control, no recurrence within 5 years, at least more than 50% of patients. So you have to review your practice, whether your outcome is better than 50%. If it is below than 50, you have to revise your practice. This slide shows the statistics in our hospital cohort at 2012. During 1 year period, we treated 300 solitary nodules. If you look at if the patients are divided by the size, here you can see the most of tumors are small tumors. I'm sure that the Vietnam situation it may not be different, but if the economy develops and in the next 20 years, your situation will be like this. This slide shows the future of Vietnam. And this red color means local ablation, RFA. Here you can see the treatment modality. The small tumor was further divided by child-pure class and presence or absence of portal hypertension. Here you can see the small tumors are commonly associated with portal hypertension, so that surgery is not usually indicated. This red color is the local RFA, and the green color is a surgical resection, and this blue one, light blue, is TACE. Here you can see the TACE is everywhere in small HCCs. So TACE plays still an important role in small HCCs. So in small HCC, our goal of TACE is not palliative. We have to perform TACE curatively. Here you can see an example, a centrally located tumor. It was precisely treated and shows no recurrence during 3-year follow-up. But in terms of local tumor control rate, theoretically, hepatic resection is best. Almost 100 no recurrence. But also RFA local recurrence rate is between 10% to 30% at most. Conventional TACE is between 70 to 50. Definitely in local tumor control, hepatic resection better, followed by RFA and TACE. How about long-term survival? So our hepatologist conducted this retrospective analysis comparing hepatic resection, RFA, and TACE in small single-node HCC. During this 2-year period, we treated 218 solitary nodal HCC, smaller than 3 cm in size. 59 was treated by hepatic resection, 87 by RFA, and 84 by TACE. This slide shows the initial outcome. At 5 years, the 5-year survival rate is 75% in TACE. It's pretty good, but RFA is better, and surgery is higher than 90%. So based on this slide, is it reasonable to say that RFA is better than TACE is better than, surgery is better than RFA, and the RFA is better than conventional TACE? In reviewing the retrospect series, we have to see these selection criteria. If you look at the baseline patient characteristics, there are enormous difference between groups. The liver function, baseline liver function is best in hepatic resection, followed by RFA, and taste group was the worst. So by correcting those baseline patient characteristics, here you can see the corrected 5-year survival rate exactly same between 3 modalities. In local recurrence rate, hepatic resection is the lowest and taste group is the highest. However, if you look at the adverse event, surprisingly, the adverse event was lowest in taste, followed by RFA, and hepatic resection is the worst. So this rise shows that it is very important to do the taste very, very safely, selectively, then safety is the best. In terms of local tumor control, hepatic resection is the best, but in adverse event and morbidity and mortality, conventional taste, highly selective conventional taste is the best. So our clinicians still send us many patients with small ACC. I will show you a very typical case. He is a 63-year-old female. He presented with rising alpha-fetoprotein during surveillance. In CT scan, no hypervascular tumor. So our hepatologist performed MRI with Primovist MRI and found 3 very tiny tumor nodules. All 3 nodules are smaller than 1 cm in size. What kind of modality will you choose? Our hepatologist referred the patient to us to treat those 3 small sub-centimeter size tumors. And we performed CMCT and found out all these 3 tumors. And it was possible to trace feeding arteries and then precisely treat those 3 tumors with minimal treatment areas, like this. After that, the alpha-fetoprotein normalized and then rise again. So CT scan was checked, but no hypervascular tumor. So our hepatologist referred the patient to us. Please check with angiography and find out the tumor. There is a tumor, so find out the tumor and treat it. So we perform CMCT and find out this small tumor. If you review carefully, there are very tiny enhancing and washout lesions, but it is not. It is basically impossible to detect. So this small tumor was also treated very well. Another recurrence, 1.7 cm in size. And during MR surveillance, and the small caudate tumor was found. And also this tumor was highly selectively treated. Still, alpha-fetoprotein is stable, but during follow-up, another 2 tumors recurred, and it was also precisely treated. So during a 7-year follow-up, 7 small sub-center tumors was completely treated without any recurrence. There are many reasons to choose a conventional TACE in small ACC. Now we know that the long-term survival is similar, and many patients, small ACC, have portal hypertension, and there are many patients with decreased performance and comorbidities, invisible lesions on CT or MR, invisible ultrasound, difficult ultrasound guidance, and suspected multiplicity, or ability to detect additional lesions using CMCT, as you saw, and availability and expertise. So I can say the role of conventional TACE in the real world is a second-line curative modality for small early-stage ACCs. Let me move on to advanced stage. This slide shows the easier guideline. Chemoembolization is high-level evidence for intermediate stage, radioembolization, but TACE is strongly it is not recommended to use TACE in advanced stage HCC with portal vein invasion in easier guideline. However, the real practice is totally different. In BCC stage in Korea, mostly treated by conventional TACE. In the 72% of patients were treated by conventional TACE in my hospital. If you look at this slide, in patient with main portal vein invasion, if the patient have Child-Pugh A disease without any bile duct invasion and metastasis, in that case, 80% of patients are treated by TACE. So even in the world, actually, stage C patients are very frequently treated by TACE. So Asian clinicians believe that intraarterial treatment with or without radiotherapy is a viable option. And even in patient metastasis, local control is very important. So many doctors worry about hepatic decompensation after TACE in portal vein invasion, but this slide shows our outcome. Our hepatologists analyzed the safety efficacy of TACE in main portal vein invasion, and they demonstrated the adverse event was not different between supportive care and TACE group, and the survival outcome is better in conventional TACE. Also, you can see the systemic review and the meta-analysis article published in 2017. If you look at the liver failure rate after TACE in portal vein invasion, it is less than 1%. So portal vein is not contraindication of TACE because only of the safety issue. And also, meta-analysis of retrospective series demonstrated the survival benefit of conventional TACE. And this is the pivotal randomized trial conducted in Hong Kong, comparing conventional TACE and best supportive care. If you look at the inclusion criteria, only the patient with main portal vein invasion and the poor performance stage 4 was excluded. It means that about 1/3 of patients had lower portal vein invasion. By including those very advanced tumors, they demonstrated survival advantage of conventional TACE. We all know Hong Kong liver cancer stage system. It is based on single center cohort. The difference between BCLC and the Hong Kong liver cancer stage system is they included ECOG-1 and the branch or portal vein or hepatic vein invasion group is included in the treatable group, and then they further divided these treatable group into 3 groups and allocated those advanced HCC into TACE group. So if you compare BCLC and the Hong Kong liver cancer stage system, about half of the patients with BCLC group belong to treatable group in Hong Kong liver cancer stage system. And this is a hypothetical survival curve. If the treatment follows Hong Kong liver cancer stage system, theoretically the survival is better than BCLC stage system. So APASL guideline include lower portal vein invasion for TACE group, and this is ASSLD guideline. The question is like this: should adults with Child-Pugh class AB cirrhosis and advanced ACC with major vascular invasion be treated with systemic therapy or local regional therapy or no therapy? The answer is like this. The AASLD recommend the use of systemic therapy over no therapy. However, it is not possible to make a recommendation for systemic therapy over local regional therapy. It means that there is no evidence that local regional therapy is better than TACE or radioembolization or any other. So we have to know that advanced ACC is a very heterogeneous group. So we can find a group which can be better managed by local regional therapy. Fortunately, now we have evidence. This study was published last year. They compared conventional TACE plus external beam radiotherapy and compared with sorafenib alone in child ACC invading portal vein. This study was conducted in Asan Medical Center in Korea, and they randomized only 90 patients into two groups because they believe that the difference is pretty big, so the calculated sample size was pretty small. And they demonstrated progression-free survival was much better in TACE plus RT group, and survival was also better in TACE plus RT group when compared to sorafenib. As you can see, all sorafenib patients died. Okay, here you can see about 20% of patients shows long-term survival. So TACE with or without external beam radiotherapy is safe and effective in portal vein thrombosis, especially in patients with good hepatic functional reserve and localized disease. I will show you two representative cases. These are pretty young patient, good performance status, child A5, high alpha fetoprotein, and you can see whole portal vein is filled with thrombus, like this. So we did the selective chemoembolization of targeted vessels, and after TACE, we additionally infused the cisplatin, 100 milligram cisplatin at these three vessels. And after single session treatment, most of the portal thrombus was decreased and some residual tumors. Here we can see 4 feeding arteries. These feeding arteries were selectively treated again, and only small residual tumor, it was also treated again. And then achieved complete response, and now he survived 1 year, 7 year, 10 year, 12 year without any recurrence. He's still alive. The second case, hepatic vein IVC invasion. On this CT scan, you can see a large tumor invading inferior vena cava. Also, the main portal vein was completely invaded. So I selectively treat the hepatic artery feeder, also phrenic arteries at the same time. After single session treatment, surprisingly, all tumors were disappeared. And he survived 4 years without any hepatic tumor recurrence. He died of metastasis. So best candidate for conventional TACE in advanced ACC, of course, good liver function patients, localized disease, nodular type will be better, and branch portal vein invasion is better than main portal vein invasion. So the second role of conventional TACE in real world is safe and effective treatment for selected group of patients with advanced ACC. Lastly, I want to introduce the recently revised Korean practice guideline. This diagram illustrates the best option and alternative option in each tumor stage. Child pure A class and no portal hypertension and ECOG 1 or 0 or 1 in patients. If there is a small tumor, smaller than 2 cm, the best option, of course, resection and RFA. And the alternative option, TACE, other local renal therapy, and external beam SBRT also can be a choice. Large single tumor, resection, and LT if the tumor size is smaller than 5 cm, RFA smaller than 3 cm, and TACE or radioembolization is regarded as an alternative option. In small multiple tumors, TACE is the primary treatment option. In small tumor invading portal vein, TACE is the first option. Large multiple tumors, TACE should be the first option. And the large single tumor invading portal vein, still TACE is the first option, like this. So in advanced stages with multiple large tumor invading portal vein, TACE plus extreme radiotherapy, and TACE is the second line option. And in patient with metastasis, TACE is regarded as the second line option. In conclusion, conventional TACE still plays an important role in management of HCCs, not only in intermediate stage, but also in early and advanced stage. Thank you for your kind attention.
Thank you very much, Professor Chung, for the presentation. We come back to the discussion. I have several questions, but I think that we left the question at the end of the section. And now I'm very pleased to introduce Professor Ho Chung Chung, who will present about the hepatic arterial infusion chemotherapy.
Okay, good morning. So I am Ho Jung-chun from the Seoul, Korea. I am an interventional radiologist and working for the Seoul St. Mary's Hospital. Actually, it is a very great honor to give you my presentations in these beautiful cities. I like Ha Long Bay and in Vietnam. So I would like to present about the hepatic arterial infusion chemotherapy in hepatocellular carcinoma with portal vein tumor thrombosis. Okay, so I will talk about the treatment strategies for hepatocellular carcinoma with PVTT, and then the hepatic arterial infusion chemotherapy. We call it the HAIC with the clinical result, and then the implantation technique for subcutaneous hepatic artery port, and then I will show some case presentations, and then I will end with the summary. Up to the 40% of the hepatocellular carcinoma patients have a portal vein tumor thrombosis. And then it may lead to a poor clinical course, more chances to the intrahepatic metastasis or tumor recurrences, and then the fewer therapeutic options. So much shorter overall survival, about the 2 to 4.6 by supportive care. And then definitely main branch PVTT has a poor prognosis compared to the branch PVTT. According to the BCLC systems, hepatocellular carcinomas with portal vein tumors belongs to the advanced stage C, and then its clinical currently standard treatment is suggested by the sorafenib. So according to the 2014 Korean liver cancer study groups practice guidelines, TACE, EBRT, and then the hepatic artery infusion chemotherapy, and they are all recommended for the hepatocellular carcinomas with PVTT. TACE is not usually recommended for hepatocellular carcinoma because of some serious complications such as ischemic event or hepatic insufficiency. Actually, so it is not real practice because theoretically this TACE may probe and causes this event. However, super-selective TACE is safe and improve the overall survival compared to the supportive care in some patients with compensated liver functions. Anyway, so TACE is not so significantly better than sorafenib so far. And then the radioembolization is another option for the treatment of hepatocellular carcinoma with PBTT, because microspheres used for radioembolizations shows if this is very small, so shows only minimal emboli effect. So radioembolization has less hospitalization, fewer treatment, and then gives the better quality of life. So it is suggested as better option than the conventional TACE. However, there is no well-designed RCT to prove the efficacy of the radioembolization in HCC with PBTT. Sorafenib is a current standard treatment for HCC with PBTT, and then the well-compensated liver functions. But there is survival benefit in sorafenib group compared to the control group in subgroup analysis with macroscopy vascular invasion. However, sorafenib showed only modest response and survival in patients with PBTT. So HAIC, the hepatic arterial infusion chemotherapy, is used treatment of HCC for over 20 years in Korea and Japan. And then the rationale of this treatment is a higher local drug concentration, fewer systemic toxicity, and then the better tumor responses than systemic chemotherapy. And then this HAIC has no embolic effect, so much safer in the hepatocellular carcinoma with PBTT compared to the TACE. So HAIC is traditionally indicated to the major portal vein tumor thrombosis, and then the TACE refractory cases. TACE refractory can be defined within 3 months after TACE, lipid accumulations less than 50% of the treated tumors, and then showing the multiple new lesions. So at the cases we can use it hepatic arterial infusion chemotherapy. There are many clinical outcomes published like so far, like these tables. So in my hospital, we performed several studies about HAIC in HCC with the PBTTs. So in these studies, comparative study of HAIC versus conventional TACE, HAIC showed longer overall survival compared to with the TACE. So So another study about the HAIC as a sorafenib versus sorafenib showed that the median survival and then the median time to progressions is longer in HAIC. And then we performed another RCT study of HAIC versus sorafenib, showed that the overall survival and time to progression were longer in HAIC. So HAIC were quite better treatment for HCC with the PBTT compared with the sorafenib and TACE. There are two infusion protocols. One is a single dose bolus infusions, and then another one is a repeated continuous infusions. For high dose chemotherapy, we always use the subcutaneous hepatic artery port because we need a repeated continuous infusion. So traditionally, this hepatic artery port system was implanted by the surgeon, and then like these pictures. However, it always needs operations, and then sometimes it may lead to many complications. So now all of the hepatic artery port are implanted by the interventional radiologist with a percutaneous technique like that. And then I want to talk about my method in my hospitals. So I usually use it 5 branches polyurethane catheter. I prepare the cell site from B. Brown, and then I make a side hole like that at the distal portions of the catheter, usually 5 centimeters apart from the tip, for microcatheter to get out for coil embolization, and then the drug release from this side hole. And then the percutaneous implantation techniques are as follows: SMA, celiac, and the common hepatic angiography, determination of final position of catheter tip, and then the hepatic artery redistributions, and then fixation of the catheter tip, and then the implantations of port reservoir in subcutaneous pocket. First, we can choose the catheter tip positions as follows. First one is end hole within the common hepatic artery, and then the second one is end hole within the right or left hepatic artery, and then we make a side hole at the proper hepatic artery. And then the third one is end hole within the gastroepiploic artery, and then we can make a side hole at the proper hepatic artery. And then we can fix it with the coembolization like that. So I usually prefer the third method because the catheter is fixed well, and then the catheter-related thrombosis is much lower. But actually, some review about this end hole technique and side hole techniques. Actually, this report showed that no significant differences between the two techniques in aspect of the hepatic artery occlusions, GI ulcers, and then the catheter dislocation and duration. So this one, I usually choose this method for normal hepatic artery anatomy. So after making a side hole here, and then I inserted catheter through the GDA, and then the coiling the GDA for fixation. And then we use the side hole for exit, for the microcatheter like this, and then the GDA and the gastroepiploic arteries can be embolized with this microcatheter. And then if there is some accessory left hepatic artery here, so from left gastric artery, before the insertions of catheter through the GDA, we always embolize the accessory left hepatic artery for hepatic artery unification. If there is a replaced right hepatic artery from SMA, I usually embolize this artery before insertion of the catheter into GDA for hepatic artery unification also. Sometimes I use another port for replaced right hepatic artery separately, like this picture. So we call it the dual port technique. So this is a case of the dual port. So this patient has a replaced right hepatic artery from the SMA, and then the left and middle segment was supplied from the proper hepatic artery from the celiac trunk. So we use two port. One is proper hepatic like this, and then another one is for the SMA. So after using this dual port, we could get homogeneous parenchymal perfusion like this. So compared to the dual port technique with the single port, we could get the homogeneous parenchymal perfusion from the dual port, and then the overall survival is quite longer with the dual port technique. So now for the cases of the replaced right hepatic artery, so we use dual port techniques for the homogeneous chemotherapy agent distribution. And then we should perform the hepatic artery redistribution to terminate the extrahepatic distribution from hepatic artery, including the right gastric artery, GDA, accessory left gastric artery, and gastroepiploic artery, for preventing GI complications by anti-cancer agent. And then we also do perform the hepatic artery redistribution to unify multiple hepatic arteries. So accessory or replace the hepatic artery, and then any extra hepatic artery collaterals, we should embolize this one previously, and then for obtaining good distribution via only one hepatic artery. This is an example of the non-hepatic artery embolization. So you can find many non-hepatic arteries here: accessory left gastric artery, right gastric artery, GDA, and then the gastroepiploic artery. So we embolized all these extrahepatic artery with microcoils like this, and then before and then after catheter insertion. This is a final result. So there is no more non-hepatic artery opacification. That means a high-dose chemotherapy from this port is safe without GI complications. So yeah, this is a movie file. Yeah, like this. Yeah. And we also use the hepatic artery unification, so embolization of accessory of non-dominant leafless hepatic artery, and then the embolization also of extra hepatic collaterals, usually including the inferior phrenic artery, suprarenal, intercostal, and the internal thoracic arteries. So this is a case. In this patient, this area, the hepatic dome is not supplied from the right hepatic artery, instead supplied from the right inferior phrenic artery. So in these cases, we should preliminary embolize this right inferior phrenic artery, and then now the whole artery levers were supplied from the only one proper hepatic artery. So we should perform in these cases, we perform the hepatic artery unifications. And then this is another patient. So you can see the left accessory hepatic artery from the left gastric artery, and then the supplies the left lateral segment. So like this. And then this accessory left hepatic artery we embolized with the vascular plug, 5 milliliter. And then after accessory left hepatic embolizations, the hepatic artery becomes unified, and then the whole liver is now supplied from the one hepatic artery. So next one is vascular access route. There are two kinds of vascular access route. So one is subclavian, and then another one is femoral artery. But you know that the femoral artery is very easy to puncture, and then we can already accustomed to this access, so we can easier insertion technique. However, the catheter may migrate because of the hip joint movement or steep outer celiac angles. In subclavian arterial access, we always use the ultrasound guidance for puncture, and then this access showed less motion dependent and less catheter migration, so we can make the patient full ambulations. But there is more complications like the brain impaction. Compared to these two vascular access, actually, so there is no no significant differences between the two techniques in the aspect of the brain infarction, catheter dislocation, and hepatic artery occlusions. However, so we studied in my hospital's retrospective review of the hepatic artery infusion port. In this patient, 400 patients, we first tried the femoral artery access in all patients, but it failed in 16 patients. So we used the subclavian artery route for them instead. So we retrospectively compared to subclavian artery port groups and then the femoral artery port groups. So subclavian group showed that a steeper angle compared with for femoral group. This is autoceliac angle. So you can see that this is very acute angles. So at the time, so we use it to subclavian artery access first. So this is quite good autoceliac angles. At the time, so we can try the femoral artery access first. And then finally, so This is final procedures as implantation of a hepatic artery port into the subcutaneous port. Sometimes we use it supragluteal, and sometimes we use it infragluteal, but there is no differences between them. And then actually, there is some complications related to port implantations. Common ones include the catheter dislocation, and then hepatic artery occlusion, and then the port infection, and then the catheter occlusion like that. So this is complication cases. You can see some microcoils protruded to the proper hepatic artery, and then we treated these conditions by the insertion of the balloon-mounted stent like that. Sometimes there might be some port reservoir thrombosis, and then it is also easily treated by the urocanase 10,000 unit packings. And then sometimes we encounter the catheter migration, because this patient always here at the side hole, and then this side also migrated to the ostium of the celiac trunk. So this is because of the acute outer celiac trunk, so it may cause the catheter migrations like that. And then also we should perform the revisions into the subclavian artery axis like this. So I will show some good response cases. This patient showed large hepatic tumors at the right lobe, and then the large portal vein tumor thrombosis like this. And then the PET-CT shows that the viable uptake in the portal vein tumor thrombosis. And then we implanted the subcutaneous hepatic artery infusion port, and then so we performed the HAIC 5 times like that. So at that time we used cisplatin and epirubicin and 5-FU, and then this is the final result after 5 times of high dose chemotherapy. So you can see there is no more parenchymal tumors, and then there is some tumor thrombosis there, but this tumor thrombosis has no viable portions inside. So in these patients, we performed liver transplantation, and then the pathologic report showed that there is no more tumor thrombosis or no more viable tumor like that. And then this is another case. Large right hepatic lobe hepatocellular carcinoma, and then the main portal vein tumor thrombosis like that. And then this patient treated by the HAIC 20 times during the 40 months. So this is and the result. You can see that there is normal tumor thrombosis, and then the normal parenchymal hepatoma, and then the alpha-fetoprotein is originally 20,000, and then now decreased to the 407. So yeah. And then I can suggest cordially new treatment algorithm for hepatocellular carcinoma, including the hepatic artery infusion chemotherapy. So HAIC, hepatic artery infusion chemotherapy, is partially indicated to the multinodular hepatocellular carcinoma, especially the 4 or more nodules, and then the portal vein thrombosis patient, especially in the major portal vein tumor thrombosis. So this is my summary. So hepatic artery infusion chemotherapy, HAIC, has been accepted as an alternative treatment to sorafenib in HCC with portal vein tumor thrombosis. And then the subcutaneous hepatic artery port implantation is very essential for HAIC. And then this technique is well established by the interventional radiologists. Thank you for your attention.
Thank you so much for the presentation. And as usual, we'll ask the question at the end of the section. And for next, I would like to introduce Dr. Thân Bien Su for the topic renal embolization. By waiting time, thank you so much for introducing the H technique in Vietnam. We just begin, and I was impressed that you started about 20 years ago. And I hope that in the future we can develop this technique in Vietnam because we have a lot of patients in this indication.
Thank you very much, Mr. Chairman. And we quickly switch topic to the kidney for the next 20 minutes or so, and I'll talk about renal embolization. Now, I think about a year ago, there was a statement from the White House of the USA about the First Lady, right? They are always in the news, but this time they were in the news for a medical problem, right? And this was that the First Lady underwent an embolization procedure to treat a benign kidney condition. The procedure was successful and there were no complications. So of course, very big impact by interventional radiology, because the next day, everybody is asking, what is embolization, right? So, as we all know, the role of embolization has really developed, and as Professor Chung also said this morning, why we have now very high resolution digital imaging for guidance, and we have new imaging techniques to help us to be even more accurate and super selective in our techniques. It's also evolved with the equipment that we use, you know, very nice microcatheters, and the range of embolic material now available to us is really wide. So if we are talking about, you know, performing embolization in the renal arterial arena, what do we need to know? So this is the scope of my talk. I'll talk a little bit about renal vascular anatomy, the indications for embolization, share with you some techniques, and also complications that can happen. Now, as we all know, classic renal vascular anatomy, the renal arteries arise from the abdominal aorta between the L1 and L2 vertebra. Usually after they arise from the aorta, they branch into the anterior and posterior divisions near the hilum, and then they further divide into apical, upper, mid, lower, and posterior segmental arteries, as shown in these diagrams. And these arteries then, segmental arteries then further branch into interlobular, arcuate, and interlobular arteries. Now, why is this anatomy important? Because you need to be aware, just as in the hepatic arterial arena, we need to be aware of variant anatomy. And typically when we perform a renal angiogram, we want to see in the nephrographic phase that the nephrogram is complete. And then we know there's no variant anatomy. However, sometimes you will get a nephrogram with a missing lower pole, and you have to think about variant anatomy. And what are the possible reasons for this? You can have very early division, and your catheter is therefore too deep into the renal artery. There are extrarenal arteries, and these are classified into two types. Accessory arteries, these are arteries that enter from the hilum, and they present in about 30% of patients. Another category are aberrant arteries, and aberrant arteries enter the renal, supply the kidney from the capsule. Okay, and if you look up the literature, there are many descriptions of the variant anatomy. I think for the purpose of my talk, I will not go into detail about this, and you need to be aware. The next concept that we need to know for embolization is the concept of whether these are end arteries or collateral arteries. And in the kidney, right, the renal arteries are end arteries. There's no anastomotic supply between the apical, upper, mid, lower and posterior segmental arteries in the majority of the situations. I think when you're dealing with tumor, and I will show you, there can be exceptions. So what is the implication of embolization? It means that when you have an artery and you block off that artery, you will get ischemia, infarction of the artery, of that segment that's being supplied by that artery. So what are the indications for renal embolization today? I think broadly described, I think into 3 areas: hemorrhage or bleeding control. If you need to perform a procedure, right, to control tumor, to get ischemia, infarction, or if you want to treat the whole kidney, to infarct the whole kidney, where you want to manage chronic renal parenchymal disease. So hemorrhage control, this is quite typical, right? Emergency, where the patient comes in with acute abdominal pain, hypotension, anemia, and you do a scan and you find that there's hemorrhage within the kidney. Here's an example: 64-year-old patient underwent by the urologist a left percutaneous nephrolithotomy, and you can see that the ureteric stent is still there. There's a big bore post PCNL catheter, but on day 2, suddenly massive microscopic hematuria. Brought the patient down. You can see that there's an ultrasound. It looks like what is a potential cyst, but if you turn on the color, this is not a cyst, this is a big pseudoaneurysm, right? So we quickly brought the patient down to the interventional suite. You can see that the left renal artery, very small caliber because of vasospasm. As you look at the later phase, you can see that pseudoaneurysm in the upper pole very nicely. And with our imaging techniques, our catheter techniques now, I think it's quite straightforward, right? Using microcatheters to go in very super selectively into that artery that is bleeding, and then just drop a couple of microcols, and you have controlled the bleeding as well as preserve the rest of the normal kidney. Now, on the other hand, here's a 29-year-old female patient presenting with macroscopic hematuria, a little bit more complex because when you perform the left renal angiogram, you can see that there is abnormal vessels, abnormal arteries with arteriovenous shunting, right? And this is an arteriovenous malformation of the kidney. You can try a few techniques because this one has got multiple feeders to the nidus. We elected to use tissue glue, and here are the images during embolization with tissue glue. There were still very small arterial feeders, and I think in this situation we elected to complete the embolization here at this point, because with arteriovenous malformations with multiple feeders, sometimes you cannot completely cure the AVM, and the key will be to control the AVM. Okay, now let me switch indication to tumor infarction and control. And here's a patient that, you know, when you do the CT scan, there's bleeding, and one giveaway about what is the cause of the bleeding is that there are areas of low density within the mass within the right kidney, and this is typical of an angiomyolipoma, right? So here's an example. There's an area of fat here. You can see embolization cause because this patient presented after many years after when she had presented acutely with bleeding, and the patient went to another hospital and they found there was a bleeding renal angiomyolipoma, and because it was an acute situation, they embolized the feeding artery with embolization cause. But if you can see from this CT scan, despite the embolization, there is still viable tumor. And here's the reason why. You can see that on the left renal angiogram, the embolization calls are there, and I think they are in a very good position. However, there's an apical artery, right, supplying the tumor, right? Because for large tumors, even though I said that renal arteries are end arteries, right, you can recruit collateral vessels, and you must be aware of that, okay? So we go in selectively into that vessel, and you can see it still supplies the tumor, and therefore it is still viable. That's why the technique for us in our practice, that when we have left renal angiomyolipoma and we want to control it, we have, you know, a different strategy of the embolic material that we use. Here's another patient, large lower pole angiomyolipoma. You can see the CT scan here. This is the left renal angiogram, a very vascular tumor in the lower pole, right? So our preferred technique is to go super selective embolization with absolute ethanol and lepidol mixture, because in this situation we want a liquid embolic material that will go all the way down to the capillary level and get embolization at the capillary level. And this is it, with the microcatheter in as deep as possible. And after embolization with the alcohol and lepidol, post embolization angiogram, you can see we have completely stripped off the vascularity of the tumor. And I would say that this is not all the time we see such a nice result, but you can see the original CT before embolization at 3 months, the tumor shrinking, and at 3 years, almost shrunk and not hardly visible. Some years back, we published our results with about 30 patients using this technique, and we showed that the radiological success is very high, and clinical success as defined as the tumor not growing further, also very high at 85%. But sometimes when there are multiple feeding arteries, it can be very challenging. And here's a 58-year-old patient that I showed you earlier, right renal angiomyolipoma, acute bleeding. Sometimes when they come in with acute bleeding and they become stable, I would not jump in to do the embolization, because I want to let the patient recover, the spasm recover, because the aim is to go in and hit it at the capillary level. So we deferred the embolization till the patient was stable, and we came in with alcohol and lepidol, right? And this is the post-embolization. And you can see that even though it's a huge tumor, it's starting to shrink after embolization. However, several years later, the patient came back after 5 years with re-bleeding, and you can see that she's bled again. So we bring the patient back, right? And this time, I think it's quite useful also to use new imaging techniques like cone beam CT, as shown by Professor Chung for the liver. And this helps us to see whether we missed any other arteries and whether there's good retention of the lepidol throughout the tumor, right? And this is it, the post-embolization, and she was fine. This is the post-embolization cone beam CT. But again, she presented with pain on the right loin after another 8 years, right? And you can see now she's bled again, and this time there's a pseudoaneurysm with shunting. So the strategy had to be different this time. So we came in and we treated this with a combination of not just only alcohol lepidol, but we also used tissue glue to close off the shunt, right? And because there were big pseudoaneurysms still, we also applied embolization calls after we have achieved distal embolization, and this is the end result, and she's not bled since then. Right, what about chronic renal parenchymal disease management? And sometimes there's a need to completely embolize a whole kidney, either to provide symptomatic relief by eliminating the renal function, to avoid surgery in patients who are not fit for surgery, right? So here's an example, 68-year-old female with transitional cell carcinoma of the left kidney, persistent hematuria, didn't bleed to the extent that she goes hypotensive, but keeps bleeding and it becomes very troublesome, right? And the patient is not fit for surgery. So it came over and we performed embolization initially with PVA particles to try and stop the bleeding. But this was not good enough because the hematuria and anemia persisted. So we went in this time a lot more aggressive to take out all of the parenchyma, and we used embolization with alcohol and lepidol, and then follow up with embolization of the main renal artery with embolization calls, and then, because we infarcted the whole kidney, the patient stopped bleeding. Now, what complications do we need to be aware of? I think post-embolization syndrome is quite common. 90% will have it. I think it's important to differentiate this from infection, so you need to be watching this very carefully. I think because, as I said earlier, the renal arteries are end arteries, you need to watch out for non-target embolization. You do not want to embolize the normal renal parenchyma if you can help it. And here's one example of a patient that came for renal angiomyolipoma embolization. Very selective embolization with alcohol and lepidol, I would say. But to the surprise of the operator, at the end of the post-embolization angiogram, you can see that there is very little peripheral opacification. I think there's pruning of the peripheral arteries of the renal kidney. I think it's because there was non-target embolization, right? For some reason, the embolic material was spilled into the main renal artery, I think. This is before embolization. After embolization, you can see hardly any peripheral opacification. And this patient, the renal function for about 2 weeks deteriorated, right? So I think this is real. So you need to be very careful, meticulous with your technique, especially if you are using liquid embolic embolization material. So my take-home points, be very familiar with the renal arterial anatomy, understand the concept of renal arteries as end arteries. I talked about the clinical indications and techniques, the strategy for partial versus complete embolization, and be aware of the complications that can happen. Cases I showed come from the team at our center at Singapore General Hospital. I just want to quickly share that at our hospital, we do offer fellowships in interventional radiology. We are very keen to have fellows from the region. We give them hands-on clinical experience, but there's a requirement. We have trained fellows from around the region as well as all over the world. But there is a requirement, if you want to get hands-on training, to have the English test to get registered with our medical council, right? And it is quite it's quite a high level of a test required. For example, the IELTS, you need to have grade 7 for all components and not just one component. All right? Okay? You can go to the website for the Singapore Medical Council to look at the standards required, and I'll be happy to talk to anyone who's interested in a fellowship. We also organize meetings in Singapore, and our interventional meeting is called WIRES, and it's happening in August this year, together with the ASEAN Association Congress of Radiology. So we'll be happy to see colleagues and friends from Vietnam attend this meeting. And of course, at the Asia Pacific level, the APSCVIR meeting is now every year. The next meeting is in Taipei, Taiwan, and look forward to seeing a big contingent from Vietnam. Thank you very much.
Thank you very much. And now I would like to reintroduce and invite Professor Ho Chung Chun come back to the stage with the presentation, the role of interventional radiology in post-liver transplantation. Please.
Okay, so my next talk is about the role of interventional radiologies in post-liver transplantations. Yes, so I will talk about the interventional treatment in post-LT complications, including the hepatic artery portal vein, venous outflow, and biliary complications. Liver transplantation was first attempted in dogs, not in humans, so from 1955. The first human liver transplantation from the 1963. This is a treatment of choice now for irreversible hepatic failure, I mean the liver cirrhosis, and then some selected cases of the hepatocellular carcinoma. So 1 year survival rate now is over than 85% because of the refinement in the surgical techniques, improved immunosuppressive agent, and then the particularly evolutions of interventional radiology. And then the interventional radiologists usually treat the post-LT complication first. So post-LT complication can be classified into the early and the late complications according to the timing. And then according to the anatomies, the post-LT complication can also classify to the vascular and the non-vascular complications. So hepatic artery thrombosis, stenosis or pseudoaneurysm, portal vein thrombosis or stenosis, venous outflow obstruction including hepatic vein or IVC, and then the non-vascular complication including the usually mostly biliary complication like bile leaks or biliary strictures, and then sometimes we treated the post-operative fluid collections including the pleural effusion, ascites or abscess. And there are two types of the hepatic artery complications. One is stenosis or thrombosis, and another one is a more serious one, is a rupture or pseudoaneurysm. And then the hepatic artery stenosis, the incidence is quite frequent, up to the 11%, and then the risk factors are like this as follows. Actually, the hepatic artery is very important for the transplantants because it provides only vascular supply to the bile duct. So if the hepatic artery stenosis or thrombosis developed, the biliary ischemia, stricture, necrosis, leaks, myeloma, and the intrahepatic abscess may develop, and finally we may lose the transplant. Usually this condition is asymptomatic, so diagnosed on the routine Doppler ultrasound, and then or MDCTs, so we should perform the conventional angiography for the confirmed diagnosis. And then this condition can be treated by sometimes immediate retransplantations, and then we can treat these conditions. We interventional radiologists use the percutaneous revascularization, and then followed by the thrombolysis, PTA, and stent. So this is a case of the hepatic artery thrombosis. The patient was presented by the only increased liver enzyme, but we could not see any hepatic artery structures on NDFCT, and then the reduced parenchymal perfusion like this. And then the conventional angiography showed that the complete occlusions of the hepatic artery by the thrombosis at the arterial anastomosis. And then it was treated by the urokinase overnight infusion. So follow-up angiography showed and then CT showed that the complete restoration of the hepatic artery flow, and then we can find the hepatic artery on the MDCT. And then this is another case of the hepatic artery stenosis. The patient was presented by the absent hepatic artery flow on routine Doppler ultrasound. So we could not see the hepatic arteries on MDCT. And then the conventional angiography showed that the tight arterial stenosis at the arterial anastomosis. So in this patient, it was treated by the PTA with a 3-milliliter balloon catheter, and then the follow-up angiography and the CT showed that the complete regression of the hepatic artery stenosis. And then the hepatic artery pseudoaneurysm is very rare, but it is very important because it is always fatal. This is usually caused by the surgical anastomosis failure or infection, sometimes by us iatrogenic related to the intervention. So treatment will always use the stent graft or coil embolization. So this is the case of the hepatic artery pseudoaneurysm. So you can see the large tumor hematoma here, and then there is a contraextravasation here, and then this contraextravasation from the hepatic artery like this. Yeah. And then this patient presented with massive bleeding from the drain. So conventional angiography showed that this contrast extravasation here. And then luckily it was easily covered by the 3.5 milliliter jaw stent. And then this jaw stent is a kind of the stent graft or covered stent for coronary intervention. So final angiography showed the complete regressions of the contrast extravasation and then the pseudoaneurysms. And then we can preserve the hepatic artery flow simultaneously. But sometimes we cannot use the stent graft because the patient is so urgent because of the massive bleeding. So in this patient, there is a big contrast extravasations here and here, and then at that time, so we don't have much time to use the stent graft, so we use the coil embolization like this. And then this is another case of the coil embolizations of the hepatic artery rupture. You can see the very big, large pseudoaneurysm here. At that time, so we have don't much time to use the stent graft, so we use the coil embolization these times. But we could save the life of the patient, but we finally lost the transplantation because in this case it's bile duct complications from the hepatic artery ischemic injury. So you use the retransplantation for this patient. And then the portal vein is also very important vascular structure, so supplying the most of the liver transplant. The portal vein complications is up to the 3%, and then usually caused by the surgical anastomosis failure or redundant vein. And then it can be presented by the absent symptoms or portal hypertension signs such as the ascites, parochial bleeding, and splenomegaly. And then we can diagnose with the Doppler ultrasound or MDCT. And then the direct photography and the pressure measurement is necessary for the confirmed diagnosis. Percutaneous treatment was performed by the transhepatic or transsplenic approach, and then the PTA and the stent with or thrombolysis is a basic treatment. And then after the portal vein interventions, we should embolize the parenchymal tract. And then sometimes we usually, sometimes a portal vein stent can be performed during the operation at the times. At that time, so we usually use the imperial mesenteric venotomy approach and then the direct stent without PTA. So this case is a typical portal vein stenosis. So you can find the very many varices here, and then this patient presented with the recurrent partial bleedings. So this direct photography showed the tight stenosis here, and then this patient simply treated by the transhepatic approach, and then the 14 millimeter bare metal stent, and then the 12 millimeter balloon angioplasties. So follow-up CT showed that much regressions of the esophageal varices, and then the favorable patency of the portal vein stent. This is another case of the portal vein stenosis presented by the severe abdominal pain, absent portal flow on Doppler ultrasound. This case was treated by the transsplenic approach like that because of the, at that time, this is a very relative immediate postoperative period, so I don't have, I cannot puncture transhepatic directly. So after the transsplenic approaches, I put and inserted some catheter, and then I used the overnight urokinase infusion. So the lesions was finally treated with the 12 millimeter self-expandable bare metal stent, and then the follow-up CT showed the completely canalization, and then the favorable patency of the stent. After transhepatic or transsplenic portal vein interventions in the liver transplantations, we should embolize the parenchymal tract for preventing the bleeding. So this is a case of the transsplenic, and then this is a case of the transhepatic. And then we can use the Gelpo MBCA coil plug, but in this time I prefer the vascular plug for this purpose. And then during the intraoperative period, sometimes we had to portal vein stent during operation. In these cases, we approach it from the open conditions, and then the direct puncture the inferior mesenteric veins, like this picture. And then so we can use the sheaths, and then we can perform any portal vein intervention like this. This is another case. There is no hepatopital flow here because of the portal vein stenosis here. Because we cannot use it PTA because this is during the operations, and then this portal vein stenosis is caused by the kinking. Yeah. So at that time, so it was treated by the 12 millimeter bare metal stent via inferior mesenteric vein venotomy approach. And then the next one is venous outflow obstruction. So there is two types. Because of the in LDLTs, we have a hepatic vein anastomosis. So there happens some stenosis or thrombosis in the hepatic vein. And then the orthotopic liver transplantation, so there is only IVC anastomosis. So problems has occurred in the IVC, like stenosis. So it can be caused as follows, like the early and late phases. And then the conventional venography and the pressure measurement is always necessary confirmed diagnosis. So pressure gradient is more than 5 millimeter Hg, so we can diagnose the hepatic vein or IVC outflow obstruction. So this is a case of the hepatic vein. Sometimes this is a treatment principle. So we can use it the transjugular or transfemoral venous approach, and then we try first PTA, and then in case of the PTA failed, for example, the immediate postoperative case, restenosis after PTA, kinking or extension compressions, we can treat it finally with the bare metal stent insertion. So this case of the hepatic vein stenosis is presented by the massive ascites and the reduced right hepatic vein on Doppler ultrasound, sound like this. So this is MDCT, so we cannot find any hepatic vein like that. And then the conventional venography showed that the tight stenosis is here, and then we treated this patient with the direct stent with the self-expandable bare metal stent. And then this is a follow-up approach and shows that the complete restoration of the hepatic vein flow. And then in the orthotopic liver transplantation patient, there happens some IVC stenosis like that. And then it can be also treated by the same method of the hepatic vein. PTA, I mean the stent or stent without stent. So this is a case. This patient was presented by the both leg edema, and then you can find a very slow, tight stenosis here and here. And then on the conventional calvography showed that the tight stenosis here, and then the much collateral to the azygos vein. And then these cases are simply treated by the 18 milliliter balloon catheter, and then the follow-up venography shows complete regression of the collateral. So this is a final result of the CT. So you can see the quite favorable patterns like that and like that with any more no more IVIS problems. And then from now, I will talk about the non-vascular complications. Actually, non-vascular complications are mostly biliary complications, and quite frequent problems after liver transplantation. So sometimes we call it the Achilles heel of the liver transplantations, and then they're usually related to the technical problems or bile duct ischemia. And then there are two types of the biliary complications. One is bile leak, and then another one is biliary strictures. So biliary complications are usually presented by the fever, pain, jaundice, and then ascites. And then sometimes no symptoms, but only have any liver enzyme abnormalities like obstructive patterns. So we can imaging diagnosis with the two-tube cholangiography, CT, ultrasound, MRCP, and then the ERCP, and then the PCTC like that. But this is a case of the bile leaks. There is three types of the bile leaks. One is anastomotic bile leak, and another one is T-tube site, and then the last one is a liver core surface. So this bile leaks is treated by the following principle. One is biloma is firstly drainage by the percutaneous catheter drainage, and then the ampullary dysfunction is corrected by the EST, and then some drainage for the external drainage for the biliary tract. And then finally we use the PTBD with the internal drainage or ERBD with the plastic stent. And then we can remove after the bile leak went away. Some biliary strictures is a relatively common problem and usually develops at the anastomosis. It is more frequent in the living donor liver transplantation compared to the orthotopic liver transplantations. Okay, so the treatment principle is same as with the bile leaks. First times we use the PTBD for external drainage for relieving the jaundice and cholangitis, and then we use the PTBD with internal drainage or ERBD with the plastic stent, and then the repeated balloon bilioplasty. Sometimes it failed. If it failed, we use the surgical conversion to the bilioenteric anastomosis. So initial PTBD, I always use the A-branch catheter, and then the repeated bilioplasty with the balloon catheter for the LDLT patient to 6 to 8 millimeter balloon, and then the OLT, I mean the CBD anastomosis, I use it the 10 to 12 millimeter. And then the internal drainage long-term keep, I should exchange it to the 14 French. And then the long-term keep should be to more than 6 months. So I always tell to the patient that you can obtain successful result without relapse as long as you use stent. So after the confirmation of the patency, we can remove the catheter. So this is a case of the biliary strictures like that. This is simply treated first with the internal drainage. And then this patient performed the repeated balloon bilioplasty, and then we keep the 14 French drainage catheters for more than 6 months. And then this is another case of the repeated balloon bilioplasty with the long-term keep of the 14 French drainage catheter in the orthotopic liver transplantation patient. Recently, we use it, retrievable metal stent can be instead of the repeated balloon bilioplasty. So this stent was designed to the late retrieval, so using the full covering and then the string for hook. Yes, so it can be easily retrieved even after 3 or 6 months by the PTBD track like this. And then sometimes biliary anastomosis can be totally occluded. So this is not so rare, up to 13% of the among biliary strictures. So before the total occlusions, we should perform the early diagnosis and prompt interventions. It is very important to preventing the total occlusions. But the total occlusion is happens, so we should carefully negotiate the wire to into the passing the anastomosis. But sometimes if the wire negotiation failed, we should puncture the bile duct like this. So we published this extraluminal recanalization of bile duct to the JVL, but at that time, so we presented the 5 cases of the puncture techniques. And then another one is, this is rendezvous techniques. Sometimes we can use these rendezvous techniques for the total occlusion patient. So this patient to show that complete occlusions of the biliary anastomosis here, and the bile leak and the biloma here. So one guide wire inserted into the biloma cavity by the endoscopist like that, and then we interventional radiologists inserted the snare catheter into the same biloma cavity. And then the guide wire from the endoscopy can be pulled throughout to the PTBD tract, and then we can use the plastic stent or internal PTBD catheter for the long-term keep. So sometimes there is some big biomas, we can use this rendezvous technique. And then another option is used by the strong magnet. This process is called the magnet compression anastomosis. 2 strong magnet approaches slow and slowly, and then the compresses the occluded portion, and then finally recanalized by the necrosis. This can be used in the choledochostomy, and then sometimes we can use the hepaticojejunostomy as well. This is a typical case. So 2 magnets were inserted from the PTBD, and another one is endoscopy, and then respectively, and then the approach together slowly by the magnetic power only, and then finally recanalized was obtained like this patient. So this is my summary. So a variety of vascular and non-vascular complications accompany the evolutions of the liver transplantation. So we interventional radiologists has contributed to extend the liver transplant graft survival by providing a reasonable alternative to surgical treatment in some types of post-LT complications. Definitely multidisciplinary approach is fundamental to decide the best suitable treatment options in the post-LT complication. Thank you so much for your attention.
Thank you. So we have our final speaker for this session, Professor Chung. He will show us some really interesting cases, and I look forward to seeing the cases.
I'm happy to share three cases. I prepared the 3 difficult cases. So number 1, tumor located in central part of the liver. This is a detail of the patient, 52-year-old female. He presented incidentally detected, no symptom. liver function is good. Platelet count is over 100,000, and child class A5. Tumor marker, PIVCA level is a little bit elevated. So tumor type is solitary nodular tumor. Size is 3.5 cm. Also, you have to have the ability to evaluate portal hypertension, the stigmata of portal hypertension, ascites, spleen, splenomegaly, and then the thrombocytopenia, and also varices on imaging studies. In this patient, no evidence of portal hypertension. I will show you the CT scan. Here you can see a tumor in the central part of the liver between the segment 4 and the caudate, just above common hepatic duct. The coronal image looks like this. So please actively participate. The questions. What's the feasible treatment option? I think all modalities have challenging technical problems. Surgery, local ablation, radioembolization, and TACE. Which one will you choose? Number 1? Number 2? Number 3? Number 4? Yeah.
But may I propose another technique is microwave ablation?
Yeah, it's included in local ablation. Yeah.
Okay.
Yeah. So our hepatologist prefer TACE, so it was requested to perform TACE. This is a common hepatic angiography. Here you can see a tumor, but there is no big difference in stain between normal liver and tumor. Sometimes hepatic artery flow is very prominent, so in that case it is very difficult to see tumor stain. So in this kind of case, if you perform TACE non-selectively, the uptake ratio between tumor and the normal liver may be not so great, so we cannot expect good response. So it is very important to perform the procedure selectively. This is selective angiography of right anterior sectional artery. Here you can see a tiny feeder. And also I selected caudate artery. Here you can see a tiny, another feeder here. So I did my best to treat all these small feeders using microcasters. In chemoembolization, including any kind of intraarterial treatment, you should be cautious about bile duct injury in this kind of central lesion. So during the procedure, if you are worrying about such a kind of biliary uptake, it is useful to check CMCT during the procedure. But in this case, this is a CT taken immediately after procedure. You can see intense bile duct uptake of the Ripardo in left common hepatic duct. So if there is a intense uptake, sometimes it can cause central biliary stricture. You should be very careful. Fortunately, in this patient, the tumor was completely regressed without any biliary complication. So this is a case of central located ACC abutting hilar biliary structure. So in this case, you always have to consider risk of central biliary restriction, not only in conventional TACE, but also in radioembolization, also local ablation treatment. Let me move on to another case. The second case is tumor growing in exophytic patient. This is a detail of the patient, 52-year-old man, no symptoms, still good liver function, but you can see a platelet count is decreased, 57,000. So Child-Pugh class is A5. Tumor marker, pivotal level is highly elevated. He had multiple tumors, 5 in number. The biggest one is 12 in segment 2, and the multiple small tumor on the right. It means that there is intrahepatic metastasis to the right lobe. And also, I emphasize the evidence of portal hypertension. In this patient, no ascites, no varices, but spleen size is 16 centimeter, and also had thrombocytopenia, so that this patient have clinical evidence of portal hypertension. I'll show you the CT scan. Here you can see a big tumor on the left, and also small tumors on the right. The tumor seems to be composed of 2 compartments. So, what is your treatment plan? This patient had bilobal ICC. The large tumor is on the left, and the exophytic growth. And also, this, even though the patient is Child-Pugh A, but have evidence of portal hypertension. Single stage TACE, or staged procedure, dominant nodule first, radioembolization or hepatic resection of dominant nodule, followed by TACE for the remaining tumor on the right. Number 1. Number 2. Number 3. Number 4. Okay. So we selected the number 2. So I will show you we decided the second option. So in this patient, right hepatic artery was the common hepatic is coming from the SMA, so it is a hepatic mesenteric trunk, but only half of the tumor is visualized. So we performed gastrosplenic trunk angiography. Here you can see the remaining half of tumor is supplied by multiple feeders from left gastric artery. So my next question is, what is your TACE strategy for left lobe lesion? TACE, the first option will be TACE for hepatic artery supply alone, followed by resection. Or second option is TACE for hepatic artery supply, plus selective TACE for left gastric artery feeders. The third is any other smart strategy. Number 1, what is your selection? Number 2, number 3. But usually in this kind of big tumors, with left gastric arterial supply, they have multiple small feeding vessels. So it's extremely difficult to manage all feeding arteries selectively. Another, if you decided to treat with TACE or both hepatic artery feeder and collateral feeder, you have to decide which one first. Left gastric artery first or hepatic artery first? Hepatic artery first. Left gastric artery collateral supply first. Okay. So I decided to use a blend gel form embolization to treat left gastric artery. In case of upper GI bleeding, we frequently perform non-selective empirical blend embolization of gastric artery. It is quite safe. So I believe that non-selective blend embolization of left gastric artery should be safe. So this is the endpoint embolization. And then perform embolization for the hepatic artery supply. So here you can see the after embolization of left gastric artery using gel form. Here you can see the lipido accumulated in the exophytic portion of the tumor. So it means that there is a communication between intratumoral communication between arterial feeders. So after single session treatment, the whole tumor was successfully necrotized. This is a follow-up taste on the second session. You can see a multiple tumor on the right. And the left gastric artery feeder was completely disappeared. And he underwent 10 more sessions of taste for the recurrent tumors for 2 years. The tumor is still good under control. Still he showed good liver function without any ascites. So this is a case of staged taste for large dominant lesion and blend embolization for extrahepatic supply from gastric arteries. In case the omental collateral is not possible to castrate, you can just blend, you can perform blend embolization. The last case is ruptured ACC with portal vein thrombosis. This slide shows the detailed clinical information. 62-year-old man. Actually, he presented with abdominal pain, so he visited emergency room. Laboratory finding was child A6, and platelet count was okay. Tumor marker alpha-fetoprotein was markedly elevated. The patient had diffuse ACC with right portal vein and the P3 invasion. It means that the patient had portogenous spread to the left. And also I evaluated the clinical evidence of portal hypertension. In case of portal invasion, it is important to evaluate the underlying liver functional status. So this patient had ascites, but because of hemoperitoneum, it is not easy to determine. Spleen size is 12, but his platelet count is good, so varices was not evident. So in this patient, the baseline liver is quite good, not so bad. So this is a CT scan. This is the DSA of this patient. You can see the whole right lobe was replaced by tumors, diffuse ACC. The right portal vein was invaded. And also you can see intrahepatic metastasis to the left lobe. So also because the tumor was very big, he had multiple extrahepatic collateral supply from inferior phrenic and renal capsular branch. So in this kind of diffuse ACC with bilobar involvement and also portal invasion, it is dangerous to treat every lesion in a single session. So I thought the patient has pretty good underlying liver. So I treated right lobe first and then evaluate tumor response. So we performed TACE using 10 milliliter of doxorubicin mixed with 50 milligram doxorubicin, and then infused the cisplatin into the right hepatic artery. Actually, we routinely infuse cisplatin after chemoembolization, only in case of vascular invasion. So after single session of treatment, the alpha-fetoprotein remarkably decreased, and he had a small amount of ascites on follow-up CT scan, so that his liver function is B7. The right lobe liver well responded to TACE. However, the P3 portal vein invasion progressed. So we treated the left lobe lesion using a small amount of Lipardo followed by cisplatin infusion. After that, tumor marker further decreased and the ascites disappeared. And this is a follow-up DSA. You can see there's some small residual viable tumor on the right. So until 2012, he underwent 7 sessions of TACE, and because of the residual tumor thrombus in right posterior section, external beam radiotherapy was performed, and then his tumor was completely regressed. Okay. However, the recurrent tumor developed on the right. So TACE was performed again. Here you can see the recurrent portal vein tumor thrombus on the right. And then he underwent external beam radiotherapy again. And his tumor marker normalized. And a single nodal tumor recurred on the left. It was selectively treated like this. And still he's alive. So this is a case of ruptured ACC with portal vein invasion and control over pathogenous spread and collaterals. I'd like to emphasize to evaluation of underlying hepatic function result and perform a safe procedure by staged approach. Thank you for your kind attention.
Thank you so much. And now do we open to the discussion, please, Professor Chung? I'm very sorry. I have some question for you. You include the hypertension, potent hypertension in the criteria to classify the hepatic tumor. The question is, you base on 3 criteria, the ascites and varice, and the size of the spleen. That's right?
Splenomegaly plus thrombocytopenia at simultaneously.
How you combine the 3 criteria to say that this is hypertension or this is not hypertension?
Excuse me?
How you combine the 3 criteria?
If anyone is positive, this patient have portal hypertension. Anyone of those 3.
Only one, that's enough to say that they have potent hypertension?
Yeah.
Okay. And another thing is very important in the decision is the condition of the cirrhosis, of the liver cirrhosis. And do you perform the elastography or something like that to evaluate the condition of the cirrhosis?
Yeah, hepatologists are doing fiber scan or something to evaluate liver cirrhosis. But as you know, it's not easy to definitely to say the patient had liver cirrhosis except the biopsy. So biopsy is not routinely performed. So I usually rely on that 3 criteria of portal hypertension. Yeah.
Only potent hypertension.
Yeah.
Okay. And in case the tumor is very small, one cm, for example, and in that case, when you perform the ambulatory CTAs, you mix also the drug with lipiodone or not, or only the lipiodone, in case the tumor is very, very small.
Yeah, in small tumors, even in small tumors, TACE should be followed by hepatic artery embolization, not only infusion of lipido and the chemo agent.
Yeah, but
the vessel should be embolized.
But when you perform the CTAs, you mix the drug with lipiodone,
Okay.
or you still mix, because in that case the dose of the drug is very small.
Yeah, in our previous case of sub-centimeter TACE with multiple, in my previous lecture, of course we mix doxorubicin with lipido, and then we embolize with gel form. But in my center, we usually mix small amount of doxorubicin in gel form because there is no evidence. But I usually mix 10 or 20 milligram of doxorubicin with the gel form and then embolize the feeding artery.
Yeah, because I don't have any evidence to distinguish between the embolization with drug mixed with lipiodone or lipiodone only. But I have the impression that in case the tumor is very small, it's lipiodone who is who have the effect.
I think you have to mix anti-cancer drug with the lipido. So lipido alone is not a good embalming material. It can be washed out. It is not a perfect embalming material. So it should be mixed with anti-cancer drug and followed by embolization if you want to achieve complete response of the tumor.
Okay, thank you very much.
Professor Chung, I have one question for you. You showed us very nice cases and you shared with us the role of local regional therapy for HCC. When are the situations that you will combine local regional with ablative techniques for HCC?
You mean TACE plus RFA?
Yes.
Yeah.
Combine TACE plus RFA. What situations?
So it is a big debate when to combine. In some centers, they even in small tumors, they just infuse lipido, and once the tumor is tagged with the lipido, they target the tumor with the RFA. But always the guidelines should follow the evidence. So if the tumor is smaller than 3 cm, there is no evidence the combination improve the survival of the patient. So, but if the tumor exceeds 3 cm, between 3 to 5, there is evidence. The combination improve the tumor response, also survival of the patient. So if the tumor is 3 to 5 cm, you can perform a combination treatment, but unfortunately there is no randomized trial comparing combination versus TACE alone. So that is the problem. If the tumor exceeds 3 cm, RFA shows high recurrence rate, so that it should be combined. But combination is not well compared with intra-arterial treatment alone.
Thank you so much. I have a question for Professor Chung. In case you perform the hepatic intra-arterial infusion chemotherapy and you have to assess femoral and subclavian, and why you perform the subclavian? Because you know that when you insert the catheter and you retrieve the sheet, it may provoke a hematoma. And why the subclavian but not the humeral artery?
You know that there are some. I mean I prefer the subclavian artery port because actually the patient is more comfortable with the subclavian artery port because it is like a CV port like that. But and then you know for the femoral access port there is some uncomfortable because of some discomfort or some foreign body sensation like the thigh or lower abdomen. So, but you know that the subclavian artery access is very somewhat difficult in technique, and then we should puncture gently, avoiding the subclavian vein simultaneous puncture. So I usually use the femoral artery access punctures first, and then we cannot insert it to the GDA or hepatic artery by the transfemoral artery access. At the case, I convert to the left subclavian artery access. You know that there is some variations between the celiac trunk and then the outer. So more than less than the 20 degree, I mean the outer celiac angles, we cannot insert it to the catheter into the GDA by the transfemoral approach. So at the time, so we should go to the subclavian artery access instead.
And how about the position to puncture? You puncture here the subclavian or the humeral? Because in the humeral case, it's easy to compress in case if there's a hematoma.
Yes, but you know that I always use it to ultrasound guided punctures. So I could not encounter some hematoma problems.
Yeah.
But after the removals of the subclavian artery port, there is some problem to the subclavian artery access site. So at that time, so I always use the closing device like angiogy like that.
Okay.
Yeah.
Okay. And for the subclavian that you use also the 5 French catheter. So the sheath is
yes. No, I don't use the sheaths. So
really?
after punctures, I directly inserted the 5 French catheter without sheaths.
Okay. Yeah. Okay. Thank you. And maybe I have a question for you. And how about the mixture between the alcohol and lipidone when you embolization of the renal artery?
Okay, thank you very much. So usually the mixture will depend on how super selective I can go and how much lipidol I need to visualize the alcohol. The purpose of using the alcohol lipidol mixture is so that I know where the alcohol is going. So if I am very super selective, I'm prepared to use less lipidol. So typically my mixture is 1:1, but I will vary that depending on how super selective I am. I think one important point to note is if you're dealing with a big tumor, you must limit the total amount or the total volume of the alcohol that you use. I think as a guide, I try not to go beyond 20 mils of alcohol per procedure. It's better to stage it. I think there are many case reports of pulmonary arterial hypertension from damage due to alcohol, so one has to be careful about that.
Thank you. But I don't know what happened if we mixture between alcohol and Genform. I don't know if Professor Chung have experience about that, but I found that if we can mix with lipiodone to inject into the renal artery, why not we don't mix with the gen form?
So the reason is depending on what the purpose is. I know that Lepidol has some embolic property, but the key thing when we mix it is for visualization of the alcohol, not mainly for the embolic ability. If you mix gel foam with alcohol, you still need to visualize your alcohol.
Yeah,
So
that's to visualize.
So do you add contrast medium or?
Yeah, of course.
But I think it's quite well known that alcohol and contrast medium, it does not mix
Yeah.
very well.
Yeah.
Yeah. So it's not something that many people would normally combine with.
So in that case, you mix with the lipiodone only for the visualizer.
Yes. I think if you find that after you get distal embolization and you want to get more proximal embolization, you can then follow up by PVA or gel foam, but you don't mix it, I think, together with the alcohol. You can do in sequence.
Because you know that when you inject lipiodone in the hepatic artery, the lipiodone don't stay everywhere. It stays only in the vascularized tumor. That means the embolic agent is not depend on the lipiodone, but it depend on the neovessel characteristic. So the neovessel in case of the angiomyolipoma is totally different from the HCC. So I don't think that's in the case of the renal arteries, the effect of the lipiodone is the same like in the case of the HCC.
I agree with you. That's why the purpose of using the Lepidol is so that I know where my alcohol is going. It's not primarily for the embolic effect. Because there are other operators, when they use alcohol to prevent reflux into non-target areas, they use an occlusion balloon. But I find that the occlusion balloon is not a very friendly way of use, although nowadays there are microcatheters with occlusion balloons, and some of my colleagues have tried that out as well. But in my technique, I prefer to go very selective, super selective with a microcatheter, and when I inject the mixture, I know exactly where my alcohol is going because it is mixed with Lepidol.
Mời bác sĩ Vĩnh có, rồi mời các đồng nghiệp khác có những câu hỏi.
Good afternoon, everybody. I'm Dr. Vinh from Bạch Mai Hospital, and first of all, I would like to thank Professor Chung very much because in 2011 I have the chance to have the visiting fellowship 6 months in the Professor Chung centers. And today is the first proponent. I would like to thank you very much for coming and for sharing your experience and lectures. So I have 2 questions for Professor Chung. The first question is, with the huge SCC with multiple filters, so should we do the embolization in one session, or we should divide in multiple sessions? And how to do the multiple session in that case? For example, about the time between the first session and the second session. And the second question is also about the huge SCC with last AP shunt. In that case, how about strategy to do to control the huge SCC? We close the AP shunt first, and then we do the conventional test, or EEB, the lock eluting bit test, or we have any option to do the huge SCC with last AP shunt? Thank you.
Thank you for very difficult questions. The first question is a large tumor with multiple feeding arteries. In terms of the safety of the procedure, maybe it is good in staged procedure. One part first and then the other part next. But in our situation, angio room is very difficult to book. So it is necessary to finish the procedure in one stage, especially in one tumor. In the previous cases, multiple tumors, so that we perform staged procedure. But if the tumor is single with multiple feeders, we usually treat in the single stage. But if you look at the literature, Dr. Miyayama in Japan, he divided the procedure in order to use more lipardo. So in single session, usually the upper limit is less than 20 or 15. So in big tumors, we cannot use enough lipardo. So Dr. Miyayama used the maximum amount of lipardo for the one part, and then next part will be treated next. So if you have room for scheduling, maybe you can choose the staged procedure, but it may increase the cost. So anyway, my choice is the single stage treatment. The next question is a large tumor with shunt, hepatic vein or portal vein shunt. In that case, the safety is preferred. Never infuse a lipardo before embolization. It may embolize to the contralateral lobe, means that normal liver, or permanent circulation. So at first, you adequately embolize the shunt using any kind of materials, PVA, gel foam. But I don't want to recommend the microspheres because it easily passes through the shunt and may cause serious problems. So sometimes a balloon occlusion technique will be useful. If there is some space to place balloon in case of hepatic venous shunt, you can occlude the balloon, you can reduce or obliterate the shunt, and then you can perform the TACE procedure safely. Any kind of measures, first embolize or obstruct the shunt, and then if the shunt is decreased or removed, then you can perform conventional TACE. But it is not, in such a kind of case, it is not possible to inject sufficient amount of lipardo into the tumor. However, please remember that there is a small difference between a blend embolization and chemoembolization. So at first, block the shunt using blend embolic materials, and then if the shunt is disappeared, then you can perform conventional TACE, lipardo infusion.
Yes, so we do it at the same session or we do it at a different session?
In the same session, yeah.
Same session, yeah.
Yeah.
Yes. Thank you.
And, may I have a question for Dr. Liu? Dr. Liu, can you share your experience, how you choose the size of the particle before the procedure?
Pharmacological department. So basically, we choose the size depends on the pre-procedure CT or MRI. And for me, I think if the tumor size is, first of all, we need to see the vascularity of the tumor. Is it hypervascular, or is there any capsule, or the size? I think is important because for HCC, the feeding artery, the size of the feeding artery correlate with the tumor size. So, for example, for me, I think if the usually I use the beats around 100 micrometer. So I think this is the sweet spot of the HCC embolization. But for especially for 3 to 5 centimeter hypervascular HCC. But if the tumor size is less than 3 centimeter, maybe I will choose a smaller size of the beads, maybe like the tendon 75 micrometer, such as that. Yeah.
Okay.
It's sometimes it's very difficult. Sometimes it's out of your expectation. Yeah.
Okay. So that means you had to recommend the size of the particle before the procedure. So
Yes. Usually, it's decided by interventional radiologists. Yeah.
So you send the paper to the pharmacy to ask to prepare it for you. That's right.
Yeah. The IR doctor, we are doctor review the images and we prescribe the size of the beads. Yeah.
Okay. Have you ever come the situation that you've already prepared, but after the angiography you found that you have to increase the size?
Sometimes, but it's very, I think it depends on the institution. In my institution, sometimes it's very difficult to ask the pharmacy to add the beads immediately because they need to prepare for at least 1 hour.
Yeah.
So if your table is very crowded, the patient cannot be wait on the table. So in that situation, I may just add the blend embolization for such as more larger beads. Yeah, or the beads in the same size, but that's a blend or gel form. Yeah.
Yeah. For example, when the patient have angio scan, we found that the tumor is a small, very hypervascularized. We prepare the small particle, but on the way that we perform the procedure, we found that there's a fistula, for example. In that case, you still use that small particle, or you change to another strategy?
You mean the, sorry? You mean the...
For example, you prepare the small particle for
Yes.
the small tumor,
Yeah.
very hypervascularized, but on the way that you perform the procedure, you found out that there's a small fistula. And in that case, you still use the small particle, or you
You mean
change?
fistula?
Yeah, fistula. Arteriovenous
shunting?
Yeah, shunting.
I think in that situation, if you can, I think under the angiogram, if you can see the shunt is not small. I think so. I think maybe you need to change to conventional, or use a lot larger bits. But sometimes it's difficult. I think I may change to conventional test.
Okay.
Yeah.
Okay, thank you.
So I have a question for Dr. Tân Bing Su concerning about the IR fellowship in your country. Now we have a lot of company can support for Vietnamese IR to go to participate in fellowship program, but the barrier or the problem is that the English level in your criteria is very high. So do you have any option for Vietnamese IR to can participate for this fellowship program?
So I think the way we have structured the fellowship is we would like the person to have hands-on, and to have hands-on to be able to participate in clinical care, you need to fulfill the English language criteria. So I would advise that if it's a young interventional IR wanting a hands-on clinical fellowship, I think English is now the language of science and of medicine. It would be good to find a way to get courses and get the English up to speed, because later as you become better well known, you get invited to give talks around the world. English is the language for communication. So it's good for all young doctors to learn English. But for more experienced IR, if you just want to come and observe a procedure for a short period of time, that is also possible. But I have to say that I think this is happening all over the world. The other requirement now to be in the hospital environment is you need to fulfill all the vaccination criteria for the hospital. So we are now becoming very strict that all the vaccination, even as an observer, you need to fulfill. Yeah.
Maybe you can tell that to the audience.
Actually, see, in Korea, so we don't have English criteria. So, so your criteria is very high.
So I thank you very much for the enthusiasm, and I would like to close this section. Thank you very much. Xin quý vị một tràng pháo tay thật vui vẻ nữa. Và mời các bạn đến Hàn Quốc. Hàn Quốc thì không cần phải tiếng Anh gì cả, mà cũng rất là tốt. Mời các bạn đến.
Thank you very much.
Thank you very much. Thank you.
Thank you. Thank you so much.
Thank you. Thank you very much.
We should have lunch.